Hello everybody, this is Dr. Nadeem and we are with Neelam Path Lectures, the Pursue series. As you are aware, all our lectures are available on YouTube. We also have a Telegram group for connectivity to access all lecture related information, a Google Drive where the lecture PDFs are all available. You have a master integration key by which you can navigate between Google Drive and YouTube. These are the disclaimers. We are with phase 3, which is recorded pathology lectures. And today we have Pursue 7P, which is Neuropathology, Hypoxia, and Stroke Session 2, which is streaming from IPGMER, Kolkata. To speak on that, we have Dr. Shristi Butta. She's an MBBS Honors Gold Medalist, MD Pathology. Presently, she's a demonstrator in an Oncopathology unit at the Department of Pathology, IPGMER, and SSKM Hospital, Kolkata. She's got 12 publications in national and international journals, with special interest in neuropathology, molecular genetics, and hematopathology. Today, she'll be taking the second session of hypoxia and stroke. Over to Dr. Shristi Butta. Ma'am, please start. Thank you.
So, very good morning. We are all set to start our lecture, part 2, on hypoxia and stroke. This is the neuropathology module 2. So, at the outset, I'd like to thank Nadeem sir for such a splendid initiative of starting a lecture series for all the postgraduate trainees. It's a highly commendable initiative, sir. Thank you. So let's start. So what do we plan to discuss today? We plan to discuss hemorrhagic stroke and its causes, particularly the intracerebral hemorrhage and the subarachnoid hemorrhage, strokes and seizures in children, pathology of seizures and intractable epilepsy or drug-resistant epilepsy, and focal cortical dysplasias. So let's start. What is stroke? Now, stroke has already been discussed in the previous class, and we had been discussing ischemic stroke, or for that matter, hypoxic ischemic encephalopathies in the previous class. Now we'd like to focus our attention towards hemorrhagic stroke. Okay, typically the intracerebral and the subarachnoid hemorrhage. The intracerebral hemorrhage, which can either be intraparenchymal or intraventricular for that matter. Hemorrhagic stroke accounts for 15 to 20% of all the strokes due to the rupture of the blood vessels causing intracerebral or parenchymal or subarachnoid hemorrhage. The major causes of hemorrhagic stroke are hypertension. Note, hypertension is a significantly very important cause of hemorrhagic stroke. Anticoagulants, cerebral amyloid angiopathies, ruptured arterial aneurysms, arteriovenous malformations, and head trauma. Hypertension, as discussed, is the most common cause of hemorrhagic stroke. A patient with long-standing hypertension usually shows a degeneration of the tunica media. See the normal diagram shown alongside. This is the tunica intima, this is the tunica media, and this is the tunica adventitia, as you can see. In a patient with long-standing hypertension, there is degeneration of this tunica media and breakage of the internal elastic lamina. There is also fragmentation of the smooth muscles of the arteries. This results in characteristic fibrinoid necrosis due to the leakage of the plasma protein or fibrin into the vessel wall. Subsequently, a lipohyalinosis develops, which is an intermediate stage between fibrinoid necrosis and a microaneurysm. So how does this lipohyalinosis look like? This is a case of a lipohyalinosis seen in a patient with long-standing hypertension. What do you see here? You see the characteristic pink or hyaline material deposited in the vessel wall. And in addition, you also see the foamy histiocytes, which have been highlighted by the CD68 antibody. And this is the immunohistochemistry for it. Right? We move on. Hypertensive intracerebral hemorrhages are typically noted in the basal ganglia and thalamus. Pons and cerebellum are quite rare sites. Now, why does a hypertensive hemorrhage develop? This typically results because of what is called as arteriosclerosis. This arteriosclerosis is nothing but the stiffening of the vessel wall. Okay, you see characteristically here, this is the hyaline arteriosclerosis, which has resulted from the deposition of the plasma proteins, which has leaked into the vessel wall. And this is the characteristic hyperplastic arteriosclerosis, which has resulted from the proliferation of the intimal smooth muscles and reduplication of the basement membrane. This stiffening of the vessel wall makes the vessels fragile. In conjunction, if there is an increased pressure within the lumen, what happens is that there is an associated vascular rupture and hemorrhage. So this hypertensive hemorrhage typically involves the parenchyma, and the most frequent sites are the basal ganglia and the thalamus. So now coming to hypertensive encephalopathy. Hypertensive encephalopathy is characterized by a clinical syndrome of encephalopathy, seizures, headache, visual disturbances, and focal neurological deficits, right? Now these clinical findings are seen in the background of severe or malignant hypertension and are usually accompanied by retinopathy and nephropathy. It must be noted that in adults, this hypertensive encephalopathy is usually the culmination of a severe chronic hypertension. However, in patients with eclampsia and those patients receiving cytotoxic or immunosuppressive therapies, hypertensive encephalopathy can develop with diastolic blood pressures as low as 100 mm of mercury. It has been hypothesized that these conditions directly elicit a toxic effect on the vascular endothelium and lead to a dysfunction of the blood-brain barrier. Now, what is the pathophysiology of it? Normally, the brain sustains a blood flow with a narrow perfusion pressure range of which is about 50 to 150 mm of mercury when considering the cerebral perfusion pressure, and or 60 to 160 mm of mercury when considering the mean arterial pressure. Note, with the increase in the mean arterial pressure, the normal mechanism is that of a cerebral arteriolar vasoconstriction. And with a decrease in the mean arterial pressure, the arteriolar dilatation occurs to keep the cerebral perfusion pressure constant. However, in cases with hypertensive encephalopathy, what happens is that these arterioles have limited ability to constrict or to relax because of the significant arteriosclerosis that has developed. Therefore, a sudden and severe increase in the arterial pressure can exceed this autoregulatory mechanism and can result in what is called as a hemorrhagic stroke. In addition, an increased intracerebral pressure can also result in a breach in the blood-brain barrier. That is, typically note the tight junctions and the astrocytic processes that form the blood-brain barrier. A breach in the tight junction results in the vascular fluid to diffuse into the capillary membrane into the brain parenchyma. So this leads to the characteristic cerebral edema, increased intracranial pressure, neurological deficits, altered mentation, visual deficits, and even seizures. So now coming to the microscopy of hypertensive encephalopathy. Hypertensive encephalopathy is characteristically associated with fibrinoid necrosis, that is deposition of a fibrin-like material that is nothing but the exudation of the plasma protein in the vessel wall. This is not only associated with hypertension, but also associated with hypersensitivity and vasculitis. Note, in vasculitis, it is often associated with antigen-antibody deposition in the vessel wall. It must be noted that this fibrinoid necrosis particularly results in characteristic thrombosis of the arterioles and capillaries and subsequently microinfarcts and microhemorrhages that subsequently develop. Now coming to arterial aneurysms. Intracranial aneurysms are also referred to as the saccular or Berry's aneurysm. So this is the characteristic saccular aneurysm or Berry's aneurysm, which is nothing but a developmental defect in the blood vessel. Okay, note the blood vessel typically involved are the vessels of the circle of Willis and their branches. This particularly develops in the wall of the major cerebral arteries at their branching points, where there is a gap in the media and the internal elastica. Okay. What is this? This is a fusiform aneurysm that you see. Fusiform aneurysms are typically elongated to spindle-shaped and they characteristically result from atherosclerosis. Okay, so when these aneurysms rupture, they characteristically cause hemorrhagic stroke, right? There is another type of aneurysm which is called the mycotic aneurysm, which develops most commonly due to endocarditis as an infected embolus, okay, enters into the distal branches of the cerebral artery, causing microinfarction or microabscess formation. Now, which aneurysm infarcts but does not cause hemorrhagic stroke? Rather, it causes an ischemic stroke. It is nothing but the fusiform aneurysm, as we've discussed. Fusiform aneurysms are vascular dilatations due to atherosclerosis, and these aneurysms typically involve the basilar arteries. They undergo infarction or ischemic stroke more frequently as compared to subarachnoid hemorrhage or hemorrhagic stroke. Now, what is this? This is a case of a Charcot-Bouchard aneurysm. It is an aneurysm which has resulted from the microaneurysms of the hypertensive stroke involving the characteristic lenticulostriate arteries, as you can see. Okay, so these are nothing but the microaneurysms seen in patients with chronic hypertension. Okay, and it characteristically involves the lenticulostriate arteries, which are branches of the middle cerebral artery. Now, when do aneurysms manifest? It is to be noted that these defects are present since birth. Okay, but however, they are very rarely expressed in children. They develop later in the adulthood, precisely when there is a gradual weakening of the vessel wall from a constant force. They are most common in women than men and occur in patients who have either a coarctation of aorta, a polycystic kidney disease, or for that matter, any connective tissue disorder which causes a gradual weakening of the vessel wall. It must be noted that there are certain risk factors which result in rupture of this aneurysm, and these risk factors include hypertension, smoking, and alcohol abuse. So now coming to subarachnoid hemorrhage. Large intracranial aneurysms can cause symptoms compressing the cranial nerves, vessels, and brain tissue, but the most feared complication is the rupture. The vessels bearing the aneurysms are basically in the subarachnoid space, and consequently their rupture causes subarachnoid hemorrhage. Okay, so as you can see in the picture given alongside, that there is an aneurysm which has ruptured into the subarachnoid space. It is to be noted that subarachnoid hemorrhage can cause a sudden headache. However, it must be noted that vasospasm develops about 1 week later, precisely due to the release of the products of hemolyzed RBCs and inflammatory products, which typically cause characteristic vasospasm. This vasospasm affects the arteries that surrounds the subarachnoid space. Now, what is to be precisely noted is the development of the hydrocephalus in patients with subarachnoid hemorrhage. Why does the hydrocephalus develop? Now, this is the normal arachnoidal granulations that you see in the subarachnoid space, which is blocked by the blood clot due to subarachnoid hemorrhage, right? Now, there may be some degree of arachnoidal fibrosis or meningeal fibrosis that is also seen, okay, because when this thrombus characteristically organizes, resulting in fibrosis. Okay, and both of these result in the characteristic obstruction of the arachnoidal granulations. As a result, what happens? There is a blockage of the CSF flow, and that results in hydrocephalus. So hydrocephalus results from two things to remember. One is the blockage that is produced by the blood clot and the arachnoidal fibrosis. Now, there is another important cause of hemorrhagic stroke, that is the vascular malformation. This vascular malformation can involve any organ and are grouped into 4 types. When it involves the capillaries, it is called as telangiectasia. It may be a cavernous malformation, also called as cavernous angiomas or hemangiomas. It may be a venous malformation, or for that matter, an arteriovenous malformation. So let's see. Arteriovenous malformations are developmental anomalies. They typically occur and they consist of a tangle of abnormal vessels. Here you see this is a normal artery and normal vein, and this is the capillary that you see here. Okay. And what happens here when there is an arteriovenous malformation, then what happens is that there is a tangle of abnormal vessels interposed between a feeding artery and a draining vein. Right? So what is this that you see here? You see vessels of variable caliber, right? So this is what we see. We see a mixture of malformed vessels such as capillaries, arteries and venules, okay? The thick-walled arteries, the thin-walled veins, and you also have the very thin-walled capillaries here, okay? And the abrupt change in the thickness helps you in identifying these vessels of variable caliber. This arteriovenous malformation typically involves the branches of the middle cerebral artery. The abnormal vessels may be in the brain tissue or in the subarachnoid space. Now coming to a cavernoma or a cerebral cavernous malformation consists of a cluster of thin-walled cavernous vessels, right? So these are the large caverns that you can see, okay? Dilated thin-walled capillaries, simply lined by a simple endothelium, and there is a very thin adventitia. Okay, they characteristically lack the elastic fibers and the smooth muscles. Now, it was previously said that a cavernoma usually does not have any intervening brain tissue. Okay, but it has been found that about 70% of these cavernomas usually have an intervening brain parenchyma. So that must also be noted. Right, so grossly this cavernoma or a cavernous hemangioma usually presents as a mulberry lesion, okay, or a purplish cluster of vessels that you see, and the diameter usually ranges from 2 millimeters to several centimeters. Up to half of the patients with cerebral cavernous malformations are asymptomatic. However, some have focal neurological deficits, headaches, and cerebral bleeds. Symptoms usually develop between the 2nd to the 5th decade of life. Approximately 20% of the cases are due to familial, autosomal dominant mode of inheritance, whereas the rest are sporadic. Familial cerebral cavernous malformations tend to be multiple. The genes typically implicated in CCM is either CCM1, 2, or 3. And patients with familial CCM or cerebral cavernous malformation have a germline mutation of one allele and acquire a mutation of the other allele, that is the second hit, during their lives. Now, what is STURGE-WEBER syndrome? Now, STURGE-WEBER syndrome, as we all know, it's a neurocutaneous disorder, right? So there is a port wine stain that you see here in the face of this woman. Okay, and it's been seen that this port wine stain occurs in the face in the distribution of the ophthalmic division of the trigeminal nerve. In addition, there is a subarachnoidal or meningeal angiomatosis that is also seen. Okay, patients with STURGE-WEBER syndrome have seizures, developmental delay, ischemic attacks, hemiparesis, headache, and glaucoma. The CT scan characteristically shows a cerebral atrophy, okay, and variable degree of calcification. Okay, so here you see the cerebral atrophy when you compare it from the other side, okay, and there is calcification as well. As we've said, there is a meningeal or subarachnoidal angiomatosis, right? So lots of vessels that you see in the subarachnoid space. In addition, the underlying brain also shows characteristic calcified vessels in the cortex. Okay, and there may be some degree of neuronal loss, gliosis, and laminar cortical necrosis. Now coming to a very important cause of hemorrhagic stroke, that is cerebral amyloid angiopathy. It is characterized by deposition of A-beta amyloid protein in the vessel wall, as we already discussed in the previous class, and this results not only in hemorrhagic stroke but also in ischemic stroke. The ischemic stroke includes microinfarcts and diffuse ischemic degeneration of the white matter, that is the leukoencephalopathy, and the patients usually have dementia. The hemorrhagic lesions include the microbleeds and the larger hemorrhages that you can make out here. Note, it has a characteristic lobar distribution, that is they occur in a location other than the thalamus or basal ganglia, which is commonly seen in hypertensive bleeds, right? So they occur in regions that are other than the thalamus or basal ganglia. A spontaneous cerebral hemorrhage in an elderly patient without an apparent cause should raise the suspicion of a cerebral amyloid angiopathy. So that is very, very, very important, right? So an elderly patient who is non-hypertensive and there is a spontaneous cerebral hemorrhage happening, think about CAA, that is cerebral amyloid angiopathies. This cerebral amyloid angiopathy is characteristically lobar in distribution and does not affect the basal ganglia or thalamus. It is characterized by deposition of A-beta amyloid protein in the small or medium-sized arteries in the cerebral cortex, leptomeninges, and even in the cerebellum. Now, coming to a crosstalk between this neurodegenerative disorder, that is the Alzheimer's disease, and this cerebrovascular process that is happening, that is the cerebral amyloid angiopathy. There is always a link between these two. You know why? This is because it's been found that apolipoprotein E4 allele is a major risk factor, not only for Alzheimer's disease, but also for cerebral amyloid angiopathy. It has been associated with neuroinflammation, synaptic dysfunction, mitochondrial or metabolic dysfunction, tau protein aggregations, and A-beta amyloid aggregations. Both of these pathologies are driven by the impaired clearance of the A-beta amyloid protein. So there is obviously some link, but the link is yet to be established. Cerebral amyloid angiopathy is increasingly recognized as a major contributor to the Alzheimer's disease pathogenesis. Okay. Now coming to the specific genotypes, yes, as we've discussed, apolipoprotein E4 or epsilon 4 is the one which allows for the cerebral amyloid angiopathy phenotype. And it is this apolipoprotein E2 which allows for a severe manifestation of cerebral amyloid angiopathies, which subsequently results in intracranial hemorrhage, right? So now what is the difference between a cerebral amyloid angiopathy and a hypertensive arteriopathy? If we sum it down, we know that a hypertensive arteriopathy usually involves the deeper vessels, unlike a cerebral amyloid angiopathy, which typically involves the superficial vessels of the cerebral cortex and leptomeninges. Okay, it must be noted in addition that microscopically a hypertensive arteriopathy is associated with fibrinoid necrosis, lipohyalinosis, and the characteristic microaneurysms, whereas a cerebral amyloid angiopathy is characteristically associated with the deposition of the A-beta amyloid protein in the vessel wall. Now coming to the other causes of hemorrhagic stroke, now this includes the anticoagulant therapies, cerebral angiitis, that is the polyarteritis nodosa, granulomatous arteritis, SLE, bacterial and fungal arteritis, cigarette smoking, alcohol abuse, chronic liver diseases typically due to the coagulopathy and thrombocytopenias that develop. The tumors that are prone to bleed can also cause hemorrhagic stroke, like the glioblastomas, lymphomas, metastatic tumors, meningiomas. Yes, meningiomas, even a benign tumor can cause hemorrhagic stroke. Yeah. Pituitary adenomas and hemangioblastomas. Now coming to stroke in children, cerebral infarction and cerebral hemorrhage in children are being diagnosed more frequently and promptly in recent years. Acute ischemic stroke accounts for about half of all the strokes in children, in contrast to adults in whom it is about 80 to 85% of all the strokes which are ischemic. Coming to arterial ischemic stroke, or the AIS, the pathophysiology and evolution of this AIS is no different from that of the adults. Okay, so as we've discussed in the previous class, we've covered the ischemic stroke. Most cases present with hemiparesis, seizures, and lethargy. Childhood arterial ischemic stroke is fatal in about 3% of the cases and causes significant permanent neurological disability in majority of the cases. What are the risk factors? Yes, it includes the cardiac disorders, that is the congenital heart diseases, endocarditis, cardiomyopathies, cardiac catheterization and heart surgery, angiopathies like the autoimmune vasculitis, infectious and post-infectious angiopathies, angiopathies associated with metabolic disorders like the Fabry's disease or the homocystinurias, systemic vasculitis like the polyarteritis nodosa, Wegener's granulomatosis, Churg-Strauss syndrome, temporal arteritis, primary angiitis of the CNS as well. All this has been covered in the previous class of ischemic stroke. Ehlers-Danlos syndrome, fibromuscular dysplasia, and genetic disorders associated with hypercoagulability like the factor V Leiden and prothrombin mutations and oral contraceptives, okay, precisely note that can also result in acute ischemic stroke. Hematological disorders like sickle cell disease and thrombotic thrombocytopenic purpures can also cause ischemic stroke in children. Now, arterial dissection, what is this? This is one of the most common causes of arterial ischemic stroke in children. It occurs either spontaneously or after a mechanical injury to the head and neck region. Genetic connective tissue disorders such as Ehlers-Danlos and Marfan syndrome may play a role in the pathogenesis in some cases. Now, what is it? The dissection of a hematoma, this is the hematoma that typically lifts the intima here. Why? Because it's formed between the internal elastic lamina here that you see, the internal elastica, and the tunica media. Okay, so this is what the hematoma is. This hematoma has lifted the intima, and there is a collapse of the vascular lumen, as you can make out. And less frequently, this hematoma can develop between the adventitia and the media. Okay, in that case, what happens? In addition to the occlusion of the vessel, the hematoma can rupture externally as well, okay, and cause characteristic headache. Now, what is neonatal arterial ischemic stroke? Now, neonatal arterial ischemic stroke is defined as symptomatic arterial ischemic stroke, typically resulting in the neonatal period, that is in the first 28 days of life. It affects 1 in 3,000 live births and is close to the incidence of an adult large vessel ischemic stroke. In the acute phase, it may be asymptomatic, but usually later patients develop hemiparesis, including intellectual disabilities, behavioral disorders, and epilepsy. Risk factors include the fetal or neonatal maternal thrombophilias. It also includes placental pathologies like the chorioamnionitis, infarcts, fetal thrombotic vasculopathies, genetic disorders like the COL4A1 mutation, which is typically associated with porencephaly, cardiac disorders, infections, and pregnancy complications. So if we come to the pathophysiology, that results in neonatal arterial ischemic stroke, we find that if there is a feto-maternal infection or inflammation, that results in the characteristic elevation of the acute phase reactants like the CRPs and other interleukins and TNF. This typically causes an activation of the tissue factor and von Willebrand factor, and there is associated platelet activation and activation of the coagulation cascade, resulting in focal thrombosis and arterial occlusion. Placental pathologies can also cause release of prostaglandins in low amounts, and that typically causes characteristic vasospasm, okay, which in turn again causes platelet activation and coagulation disorders. Now coming to cerebral venous thrombosis. Cerebral venous thrombosis is a very important cause of ischemic stroke in children. Typically, it involves the superior sagittal sinuses, inferior sagittal sinus, straight sinus, transverse sinus, sigmoid sinus, cavernous sinus for that matter, and also the internal jugular vein, right? Now, what is the pathophysiology? As we know that the cerebral vein thrombosis results in characteristic rise in the venular or capillary pressure. A rise in the venous pressure causes a decrease in the CSF absorption in the veins, and that results in the characteristic rise in the intracranial pressure. This rise causes a headache, focal neurological deficits, and seizures. A rise in the intracranial pressure also causes a decrease in the capillary perfusion, ischemic injury, and a characteristic cytotoxic edema. There is also disruption of the blood-brain barrier, which causes characteristic interstitial or vasogenic edema. Venous and capillary rupture also might result in a parenchymal hemorrhage, which also results in headache, focal neurological deficit, seizures, and an altered mental status. Now, childhood strokes can also be hemorrhagic. So about half of the strokes in children are hemorrhagic, and the anomalies that have already been discussed in adults include the saccular aneurysms, the arteriovenous malformations, cerebral cavernous malformations, coagulopathies, brain tumors, sickle cell disease. Patients present with headache, altered mental status, nausea, vomiting, focal deficits, and seizures. The pathogenesis and pathology is quite similar to that seen in the adults. Now, finally, we come to the pathology of seizures. Now, what are seizures? Seizures are nothing but the paroxysmal discharges from groups of neurons which arise as a result of excessive excitation or loss of inhibition. Okay, so the key unit of neurotransmission is the synapse. And the fundamental components of the synapse are the ion channels, right? So this is what has been shown here. The fundamental component of any seizure to develop is a dysfunction in the ion channel. Seizures can either be generalized, tonic-clonic, partial, or focal. So about 1/3 of seizures are caused by genetic abnormalities characteristically involving the ion channels. A quarter or so are caused by structural lesions. Some of these lesions include the brain tumors, traumatic brain injuries, infections, perinatal brain lesions, and some of the lesions are even environmentally acquired. So just to note that in addition to the genes and environment, brain development has a strong influence on seizures. Synapses are in a state of flux during adolescence and childhood. First, they proliferate excessively and then they reduce in number in adults. So this is because of the dynamic state of the synapse, and that explains why most seizures begin and often stop for no apparent reason during childhood. Okay, it is because the synapses are in a constant state of flux. Okay, and they are either proliferating excessively and then reducing in their amount in adulthood. And that is because of this dynamic nature of the synapse, which results in the characteristic variability in the manifestation of seizures in childhood and adulthood. Now, structural lesions are frequently detected in focal seizures. The most common lesions are the cerebral changes resulting from perinatal brain damage, malformation, cerebral infarcts, trauma, brain tumors, and infections. These lesions characteristically involve the cerebral cortex and are associated with neuronal loss and gliosis. Note, neuronal loss and gliosis. So now coming to the pathology of drug-resistant epilepsy. Cases of epilepsy that do not respond to drugs usually require surgical interventions. So what are the microscopic features of such cases will be discussed in the next few slides. The most important manifestation is the focal cortical dysplasia. Focal cortical dysplasia is a heterogeneous group of disorder which can be caused by a drug-resistant or intractable epilepsy. It's a malformation of the cortical development. Remember that there is a disturbance in the cortical layering and architecture. This was first introduced by Taylor in 1971 and is one of the most common structural lesions in children with intractable epilepsy. It presents as a localized lesion. So what is focal cortical dysplasia? Let's see. Now this is the normal cerebral cortex and these are the neurons, as you can make out, which has been highlighted by the new N immunohistochemistry. This is the characteristic hexagonal arrangement of the cerebral cortex. In focal cortical dysplasia type 1, which has been divided subsequently into type 1A, 1B and 1C, what is found is that there is an abnormal vertical architecture in 1A, abnormal tangential layering in 1B, and both abnormality of the vertical and tangential architecture in 1C. Now let's see. In type 1A, as I said, that there is an abnormal vertical architecture. That is, there is formation of microcolumns. What are these? These are microcolumns. These microcolumns usually have more than or equal to 8 neurons and they typically involve the layer 3 of the cerebral cortex. Okay, so if we see it under the high power, we see that there are more than or equal to 8 neurons in layer 3, typically arranged in a vertical fashion. Now in 1B, what happens is that there is an absence of a recognizable layering pattern. Okay, that is, there is an abnormal tangential pattern. So what do you see? There is no characteristic distribution in the tangential arrangement of the neurons that you can make out. And there is also loss of layer 2 and layer 4. Okay, which has characteristically been lost. So the most important thing is the chaotic distribution that you make out, that is the tangential distribution of the neurons is completely lost. In 1C, there is both, that there is abnormal vertical and abnormal tangential distribution of the neurons. However, even the neuropathologists feel that whether this entity exists or not is quite a doubt. Coming to focal cortical dysplasia type 2, in addition to the cortical dyslamination, that is an abnormality in the cortical arrangement of the cells, there is also dysmorphic neurons and dysmorphic neurons with balloon cells, as seen in focal cortical dysplasia type 2B. So what are dysmorphic neurons? So this is what you see. These are the dysmorphic neurons. Why are they called dysmorphic? Because they have an abundant bluish cytoplasm, as you can make out. This abundant bluish cytoplasm is because of the abnormal Nissl granules. The coarse Nissl granules have been abnormally distributed here. Okay, unlike a normal neuron, and they have also increased in size as compared to a normal neuron, right? Now, what are balloon cells? Balloon cells have large amount of glassy eosinophilic cytoplasm. So this is what you see here. You have a large amount of glassy eosinophilic cytoplasm without any processes. Okay. And they have a characteristic ambiguous neuronal and glial feature. That is, they are positive not only for the neurofilaments and NEU-N, but also for GFAP. This type of cells have also been noted in patients with tuberous sclerosis. So in addition to the intractable epilepsies, these balloon cells have also been noted in tuberous sclerosis. Now, what is focal cortical dysplasia type 3? In addition to the cortical dyslamination, that is an abnormal arrangement of the cortical neurons, there is also hippocampal sclerosis noted in 3A, an associated brain tumor in 3B, an associated vascular malformation in 3C, and there is an associated history of perinatal or neonatal ischemic event in 3D. So now coming to the normal structure of the hippocampus. As you can see that hippocampus is located in the deeper part of the temporal lobe, okay, and has a dentate gyrus, and in addition also has the cornu-amnois, okay, which can be either 1, 2, 3 or 4. Okay, so there are 4 types of cornu-amnois, that is CA1, 2, 3 and 4. In addition, there is also a subiculum that is a part of the hippocampus. So now we see the normal neuronal distribution of the neurons in the hippocampus, that is in the dentate gyrus and the cornu-amnois 1, 2, 3 and 4. Okay, so what do you see here in this picture? Let me just show you with a laser pointer. Yes, you see the normal neurons in the dentate gyrus and in the cornu 1, 2, 3 and 4 as discussed. And this is the NEU-N immunohistochemistry that has been used to highlight the neurons. The NEU-N immunohistochemistry shows that there is a loss of neurons typically in the cornu-amnois 1 region as shown in the figure B. Whereas in the figure C, you see that there is a typical loss of neurons in the cornu-amnois 1 and 4. This is called as the classic hippocampal sclerosis. Whereas in the figure D, you see that there is a neuronal loss involving all the cornu-amnois regions or sectors of the hippocampus. However, the neurons in the dentate gyrus are preserved. Now, it is presumed that the mechanism of damage in the hippocampal sclerosis is precisely due to the release of the glutamate, which is the excitogenic neurotransmitter during the epileptic attack. And the most frequent site of damage is the CA1 sector of the hippocampus. So if we divide the hippocampal sclerosis into different patterns, we find that there is a classic pattern of hippocampal sclerosis and there is a severe hippocampal sclerosis as shown in figure D. Now, besides that, you must also remember that what is mesial temporal sclerosis? Mesial temporal sclerosis, as you can make out in figure A, there is no loss of neurons and all the neurons in the dentate gyrus and in the CA1, 2, 3 and 4 sectors are normal. So there is no mesial temporal sclerosis. In the figure B, where you have a mesial temporal sclerosis type 2, where there is characteristic loss of neurons in the CA1 region. In figure C, what you see is that this is a mesial temporal sclerosis type 1A or the classic hippocampal sclerosis where there is a significant loss of neurons typically in CA1 and 4. In the D, what do you see? This is a mesial temporal sclerosis type 1B or a severe hippocampal sclerosis where there is a total loss of neurons in all the 4 sectors of the hippocampus. However, it must be noted that besides the focal cortical dysplasias, intractable epilepsy and status epilepticus also show neuronal loss in the cerebral cortex, thalamus and or cerebellum, typically the Purkinje cells. So if we summarize both the lectures, that is part 1 and part 2. In the part 1 where we discussed ischemic stroke, that precisely resulted from a small artery occlusion or a large artery atherosclerosis or an embolism for that matter, resulting in a cerebral hypoperfusion, oxidative damage, necrosis, anoxic neurons, an iron pump failure resulting in the characteristic edema and inflammation subsequently, a decreased oxygen and glucose which resulted in characteristic lactic acidosis and edema and inflammation. And today what we've discussed, that is the hemorrhagic stroke, which has different etiologies like the antithrombolytic therapies, cerebral aneurysms, hypertension, arteriovenous malformations, or it may be due to head trauma, all of which results in a cerebral hypoperfusion, which may either be resulting in a lactic acidosis or RBC lysis and an oxidative damage, all resulting in a cerebral edema, a decreased ATP, resulting in necrosis and subsequent inflammation. And finally, we also discussed the intractable epilepsy or the drug-resistant epilepsy, which basically results from focal cortical dysplasias, which are of three types, type 1, 2, and 3, of which type 1 is basically due to the abnormal vertical or tangential arrangement of the neurons in the cortex, whereas type 2 typically results from cortical dyslamination with dysmorphic neurons and or balloon cells in type 2A and 2B respectively. And in type 3, where in addition to the cortical dyslamination, there is either hippocampal sclerosis or associated brain tumors or arteriovenous malformations, or for that matter, a perinatal or neonatal ischemia. So finally, we've come to an end of today's lecture. And these are my references both for Module 1 and Module 2. Thank you so much for your patient hearing.